Unlike some of the patients that you may have cared for in the hospital, most pain during childbirth is anticipated and it results from normal physiological events. So, with this chapter, I'd like to talk to you about pain management in labor. During the first stage of labor, if you'll remember, is when the cervix is thinning out and dilating. Visceral pain results from uterine contractions leading to uterine muscle hypoxia that results in a lactic acid accumulation. There's also cervical and lower uterine segment stretching, traction or tugging on the ovaries, fallopian tubes, and the uterine ligaments, and pressure on the bony pelvis. Generally, during the first stage of labor, women experience pain only during contractions, with the exception if their fetus is in that occiput posterior position and they have that horrible continuous lower back pain. During the second stage, or the pushing phase, she may be experiencing some somatic pain from perineal stretching and pressure against the bladder and rectum. This somatic pain manifests as supralocalized, intense, sharp burning pain in the perineum. The third stage is when the placenta is separating and it's getting ready to be delivered. Isn't as painful in comparison to late in the first stage and second stages of labor. The third stage usually feels like uterine cramping or contractions, like early in the first stage. As we know, everyone's pain tolerance varies, but what pain tolerance? It refers to the level of the laboring woman is willing to endure. When this level is exceeded, she will seek measures to relieve that pain, whether it be pharmacological or non-pharmacological. Some factors that influence her pain tolerance are her preparation for childbirth, her desire for a natural vaginal birth, her willingness to participate in non-pharmacological measures for comfort, and her willingness to request pharmacological relief measures. During labor, pain is expressed in a variety of ways. The blood pressure and the heart rate increase in response to the catecholamine levels. You'll see respiratory pattern change due to increased oxygen consumption. Hyperventilation can occur as the pain intensifies, and that's going to be evident by the patient feeling lightheaded, dizzy, and the hands go numb. She may have pallor and diaphoresis. Gastric acidity increases, leading to nausea and possible vomiting. Placental perfusion may decrease and uterine activity may diminish, prolonging the labor and affecting the fetal well-being. So there's a point when that pain can be contraindicated from the standpoint that it can slow everything down, and we need to get that woman as relaxed as possible to help speed up her labor. In non-pharmacological pain management, research some examples of non-pharmacological pain management include music, meditation, guided imagery, massage, counter pressure, which is really helpful when the baby's presenting in an occiput posterior position, and that would be when the support person would take a ball or just the palm of their hand and they're going to push it into the lower back kind of as a counter pressure during the peak of that contraction. Slow paced breathing we often use. Sometimes touch or effleurage is a fanning out of your hand in a massage like fashion. Women should be encouraged to communicate these to their healthcare providers, and we need to assist them in using these if she requests to do so. I've noticed that many of these techniques aren't used as often as they used to be due to an increased use of epidural catheters. If the support person isn't able to guide the woman in these methods, it's important that we role model how to do that and how to help the woman through this time until and if she chooses to use a pharmacological pain method. You may have heard of gate control theory. Gate control theory of pain is a lot of technical terms that you can read about in your text, but basically there's a limited number of sensations or messages that can be sent to the brain at one time. Therefore, if you're distracted with massage, focal points, slow breathing, you're less likely to feel as much pain. Although most often the laboring woman has someone to support her in labor. The goal to provide pharmacological pain management is to give the maximum pain relief with the minimum risk to the mother and fetus. This goal is impacted by some of the following factors. All systemic drugs used in labor for pain relief cross the placental barrier by simple diffusion. That means that there's no way to give these medications without the baby receiving some of it. Drug action in the body depends on rate at which the substance is metabolized by the liver, and the fetus has inadequate ability to metabolize the analgesic agent. Two common opioids are morphine and fentanyl, and some IV opioid agonist-antagonists are Stadol and Nubane. Something to note that we never want to give a narcotic agonist-antagonist to a woman with narcotic dependency or abuse, as immediate withdrawal will occur and can stimulate seizures. So if the laboring woman has decided that she wants something in her IV for pain management, we need to make sure that her maternal vital signs are stable. And we also want to look at her fetal heart rate tracing and make sure that she has at least average variability with some accelerations before giving systemic drugs, because they have a tendency to decrease maternal heart rate, respiratory rate, and blood pressure, which then could affect fetal oxygenation. So we want to start out with a really healthy baby before we give the IV medications. It's not uncommon to see a decrease in fetal heart rate variability for about 10 to 30 minutes after we give the systemic medications to the laboring woman. Some of the advantages are that they're easy to administer, they're quick, they take effect really quickly, and the ease of administration, they're just pushed in the IV safely, relatively short duration, and that's important if she's progressing at a very rapid rate. If we think delivery is going to be fairly quick, we don't want to give it too close to the time of birth. Some of the disadvantages of giving IV opioids is that they may decrease contraction frequency and intensity, so you kind of have to stagger it. You don't want to give it too early in labor, but you also don't want to give it too late. It does cross the placenta, so it results in neonatal respiratory depression if given too close to delivery. Once that baby's delivered, we want to make sure that it doesn't have any of that in its system, and we may need to give Narcan if it just happens that she delivers quickly after the medication. But it does have relatively short duration. That can be an advantage if she's going to deliver quickly, but if she's not, if it's a prolonged labor, it's not going to give her adequate pain control when that wears off. Now I'd like to talk to you about epidurals, certainly the most popular and most well-known of all the pain medications currently in labor and delivery. An epidural is a catheter that gets threaded in between the fourth and fifth lumbar vertebrae. They're going to inject some local anesthetics such as Marcaine or bupivacaine and possibly an opioid analgesic such as fentanyl. It blocks from the thoracic level 10 down to S5 for vaginal births, and if it's given for a cesarean section, they're going to block from T8 to S1. It's administered in the side lying or sitting on the side of the bed with the back curved out. That's the most common. The patient must hold still during the insertion, and this is super hard during contraction. So we try to do, the anesthesiologist or the nurse anesthetist tries to do this in between contractions, but there may be a point when you're going to have to hold that patient still. We're going to monitor urinary output because it's not uncommon to have urinary retention because the woman will be numb down below and she won't feel that urge to void. So she may need a Foley catheter as a result. But the biggest and most obvious side effect is going to be maternal hypotension because of the vasodilation. So we're going to monitor her blood pressure very, very carefully, usually every 1 minute for 5 minutes, every 5 minutes for 15 minutes after insertion. We're going to avoid the supine position, and if we do have to keep them directly on their back, we're going to put a hip wedge under to help prevent the blood flow being occluded for the baby. We must turn the patient frequently, every 30 minutes to an hour, to help it distribute evenly to all areas because it's a regional anesthetic, meaning it goes to the point that's down. So if she's laying on her left side, it's going to go towards her left hip and her left side of her abdomen. So we want to keep turning her back to back, or excuse me, side to side. We do have some safety concerns just because her lower extremities are going to be very numb. She's not going to be able to lift her butt off the bed, or she may have difficulty with that. She's going to be a risk for fall until this is completely worn off. So we want to remember that as we're taking care of a patient immediately postpartum, that they may still have some residual epidural on board, and when they get up to go to the bathroom, we're going to have to be with them to help steady them so they don't have their leg give out on them. Some of the epidural side effects are maternal hypotension immediately following insertion is the biggest side effect. We preload that patient with a crystalloid IV solution, such as normal saline and more often lactated ringers, before we give the epidural. Emergency maternal hypotension with decreased placental perfusion, I would review that in your textbook. This can result in uteral placental insufficiency and decreased oxygen to the fetus. So when that maternal hypotension occurs, it's going to decrease the blood flow to the placenta, which then decreases blood flow to the baby and can affect the heart tones and oxygenation for the baby. So urinary retention due to not feeling sensation to void, as I mentioned. They may become itchy because of the fentanyl if that's used in the epidural solution. They have an increased risk of prolonged labor and the use of forceps. And you can see here where the contraindications, and there's a nursing care plan that you can review. But as I mentioned, some of the advantages are the excellent pain relief, and they may actually have some postpartum relief as well. Disadvantages: the time involved with setup and administration make it undesirable if the labor is progressing rapidly or in the transition phase of labor. It also must be inserted by anesthesia personnel, and it usually causes numbness to lower extremities, which limits the mobility of the patient. It decreases contraction frequency and intensity at times and may require augmentation with Pitocin to achieve adequate contractions. Contraction intensity may be difficult to detect because she'll be numb, and it may require the use of an intrauterine pressure catheter to monitor those contractions. Little or no urge to push is felt with some epidurals, necessitating some to be turned off when the patient needs to push. She may have nausea, itching, urinary retention, and muscle spasms at the site when using an indwelling epidural catheter. Now I'd like to talk about spinal anesthesia. Spinals are generally used for C-sections here regionally in this part of Michigan. Local anesthetic or combined with opioid analgesics is injected through the third, fourth, or fifth lumbar interspace into the subarachnoid space. Positioning is similar to the epidural insertion, where she's going to be sitting up at the bedside holding completely still and arching her back. We need to displace that uterus to the side by putting a wedge under one hip when lying down to prevent supine hypotensive syndrome. The side effects are maternal hypotension, impaired placental perfusion, and ineffective breathing pattern, if she does get the maternal hypotension. Assess maternal vital signs and check that fetal heart rate at least every 20 to 30 minutes. Give 500 to 1,000 liters of lactated ringers or normal saline 15 to 30 minutes before insertion to prevent maternal hypotension. And at last, I'd like to talk about general anesthesia. That's used primarily for cesarean sections in emergency situations, or for women who don't want to be awake during surgery, or when the woman has contraindications to an epidural or spinal anesthesia. The risks include difficulty intubating the patient, or they may be at risk for aspiration of gastric contents. The woman should be NPO. They want to take an oral antacid such as bicitrate. Recommendation to pre-oxygenate the patient and use a hip wedge. Again, that's to prevent that supine hypotension when they're going under anesthesia. Delivery of the fetus as soon as possible, within minutes after administration of anesthesia. So they're going to get everything all ready, get the whole room ready, then they're going to put the patient under, lay the patient down quickly, put that hip wedge in, and then they're going to start that C-section. They want to get that baby out within 3 or 4 minutes to make sure that the baby has the best possible outcome. So this concludes our pain management in labor. I hope you have a wonderful day. If you have any further questions, don't hesitate to ask your clinical instructor or your theory instructor. Take care.